If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. In today's episode, we look at the NICE updates published in June 2026, focusing on what is relevant in primary care only. This month, the main update is the guidance on bempedoic acid with ezetimibe, although we will also touch briefly on ectopic pregnancy and miscarriage, postnatal care and multiple sclerosis. Right, let's jump into it. And let's start with a new guidance on bempedoic acid with ezetimibe for treating primary hypercholesterolemia or mixed dyslipidemia. But first, what is bempedoic acid? Bempedoic acid is a relatively new oral non-statin lipid-lowering drug used to reduce LDL cholesterol. It works in the liver by inhibiting cholesterol production earlier in the pathway than statins. Because it is activated mainly in the liver rather than skeletal muscle, it can be useful when statins are not tolerated, particularly because of muscle symptoms. The result is reduced cholesterol synthesis in the liver and increased clearance of LDL cholesterol from the blood. Bempedoic acid is usually given with ezetimibe because the two drugs work in complementary ways. Bempedoic acid reduces cholesterol production in the liver, while ezetimibe reduces cholesterol absorption from the intestine. Together, they lower LDL cholesterol more than either drug alone, and they will provide an all-oral option for people who cannot tolerate statins. Now let's look at the NICE guidance. In the NICE guideline, bempedoic acid with ezetimibe is an option for adults with primary hypercholesterolemia or mixed dyslipidemia only when statins are contraindicated or not tolerated, and ezetimibe alone has not controlled LDL cholesterol well enough. The evidence shows LDL cholesterol reduction with cardiovascular outcome evidence. In practical terms, this is not a replacement for statins as first-line lipid-lowering treatment. NICE describes the usual pathway as statins first, with ezetimibe added if LDL cholesterol is not lowered enough. NICE also notes that there was no direct comparison with PCSK9 inhibitors such as alirocumab or evolocumab. An indirect comparison suggested bempedoic acid may be less effective than these options. However, a useful practical point is that bempedoic acid is an oral treatment, whereas alirocumab and evolocumab are given by subcutaneous injection. Despite those uncertainties, NICE concluded that bempedoic acid with ezetimibe is a cost-effective option for people with primary hypercholesterolemia or mixed dyslipidemia where statins are contraindicated or not tolerated, and ezetimibe alone does not control LDL cholesterol well enough. Let's now move to the updated guideline on ectopic pregnancy and miscarriage. The main change affects secondary care, but it is useful for us to know that anti-D immunoglobulin prophylaxis is no longer offered for ectopic pregnancy, miscarriage or threatened miscarriage up to and including 11 weeks and 6 days gestation. However, from 12 weeks and 0 days to 12 weeks and 6 days, anti-D remains relevant for rhesus-negative pregnant people. And while we're here, we should remember that in any woman of reproductive age with non-specific symptoms, we should consider pregnancy and think about offering a pregnancy test. We should also refer to early pregnancy assessment services if there is bleeding or pain, and the pregnancy is of 6 weeks or more, or the pregnancy is of uncertain gestation. The urgency will depend on the clinical situation. If the pregnancy is under 6 weeks, there is bleeding but no pain, and there are no risk factors such as a previous ectopic pregnancy, NICE recommends expectant management. We should advise them to return if bleeding continues or pain develops, to repeat a urine pregnancy test after 7 to 10 days, and to return if it is positive. A negative test will mean that the pregnancy has miscarried. Let's now touch on the updated guideline on postnatal care. For GP practice, the June 2026 update itself probably changes very little. NICE has added a recommendation to offer vitamin K prophylaxis to babies, linking to the intrapartum care guideline. For primary care, the main practical message is unchanged. The 6 to 8 week postnatal check remains an opportunity to assess maternal physical and mental health, contraception, pelvic floor and perineal problems, bleeding, safeguarding, feeding and the baby's well-being and development. And finally, the updated guideline on multiple sclerosis. The main change is diagnostic. The guideline now refers to specialist criteria known as the McDonald criteria, and NICE has removed the old statement that MS should not be diagnosed solely on MRI findings. But this does not affect us in primary care. For us, the practical message is that we should think of multiple sclerosis when there are focal neurological symptoms evolving over more than 24 hours, lasting days or weeks, often improving afterwards, and not explained by any other common diagnosis. However, we should not routinely suspect MS from fatigue, dizziness or vague sensory symptoms alone. We should then refer suspected MS cases to neurology, and secondary care will make the diagnosis following specific criteria. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.